Well, hello. My name is Jackie Druin. I'm the current president of IPT-HOPE, that's International Physical Therapists for HIV/AIDS, hospice and palliative care, and oncology. And we're a subgroup within the World Physical Therapy Association. And I'd like to welcome all of you in the audience today to this presentation. It's going to be really good because I've seen it already at CSM, and it's very organized and very hands-on information, even though it's online. And I'd like to thank speakers. Our speakers are from Memorial Sloan Kettering Hospital in New York, and they're Jennifer Bohinski, Helene Firestein, Janelle Ianello, and Jennifer Miguel. So I'd like to thank the four of you for coming and presenting to us today. And what I'd like to do now is hand this over to the speakers. They'll tell you a little bit about their background, and then they'll proceed with this presentation. And I love the title, Say Cheese. So without further ado, go ahead, take it away.
Thank you for that introduction. So bear with me, I'm just going to share my screen. All right, can everyone see my screen okay? Great. So hello everyone, and welcome to our presentation, like mentioned, titled Say Cheese, Helping Patients with Head and Neck Cancer Smile, an Acute Care Perspective. My name is Janelle Ianello, and like also mentioned, my fellow presenters are Jennifer Bohinski, Helene Firestein, and Jennifer Miguel. So being that our presentation title emphasizes the old saying, say cheese, we felt it was only fitting to start our presentation by showing you a picture of us smiling and to give you some background information about us as physical therapists. We are all PTs at Memorial Sloan Kettering Cancer Center in New York City. Helene and Jennifer Miguel also treat in our outpatient pediatric setting as well. We are all also certified lymphedema therapists. So not only do we have experience in treating patients with head and neck cancer for physical therapy, but for lymphedema therapy as well. We have no financial disclosures or conflicts of interest. Our objectives today are to understand head and neck cancer diagnoses and medical interventions, to identify the common side effects from treatment from an acute care perspective, to describe physical therapy interventions to address side effects from treatment, and to discuss how to navigate physical therapy care from head and neck surgeries, including addressing reconstruction precautions, head and neck lymphedema, and facial reanimation. This is just a brief outline, so we'll be starting with an overview. We'll get into head and neck cancer treatments. We will then look at physical therapy considerations and interventions, and then we'll be looking at some case studies as well. So we wanted to start our presentation with the basics, anatomy 101, if you will, just so that we can refresh your memory about the anatomy and physiology of the components of the head and neck cancer regions. The title head and neck cancer can seem very broad, so I'll be narrowing down the specifics as to where cancers from the head and neck can form, and this will be referenced throughout the entire lecture. Starting with the oral cavity. The oral cavity is composed of the lips, the front 2/3 of the tongue, the gums, the cheeks, floor of the mouth, under the tongue, and the hard palate, and a small area of the gum behind the wisdom teeth. The function of the oral cavity is the first structure of the digestive tract and its secondary respiratory pathway, and is the site of sound modification for speech. Next, we have the pharynx, or in simple terms, the throat, which is a fibromuscular tube about 5 inches long, starting from behind the nose and leading to the esophagus. The pharynx includes 3 parts. The nasopharynx is the upper part of the pharynx, and it's located behind the nose, superior to the soft palate and back of the mouth. The oropharynx is the middle part of the pharynx, and it includes the soft palate superiorly, and the posterior 1/3 of the tongue, and the epiglottis inferiorly. It contains the palatine tonsils. And then last is the hypopharynx, which is the lower part of the pharynx, and it's defined by the epiglottis superiorly, the cricoid cartilage, and the esophagus inferiorly. And the hypopharynx communicates directly with the larynx. The function of the pharynx as a whole is that it serves as a continuation of the digestive and respiratory pathways. Next, we have the larynx, also known as the voice box, which is anterior to the inferior portion of the pharynx and superior to the trachea. On men, this can be referred to as the Adam's apple. It is composed of cartilage and a number of intrinsic muscles. It functions to protect the lower airway by closing upon mechanical stimulation, halting respiration, and preventing foreign matter from entering the airway. The epiglottis moves inferiorly to cover the larynx during swallow. In addition, the larynx contains two muscular bands known as the vocal cords, and it is involved in sound production, cough generation, the Valsalva maneuver, and the control of ventilation. Next is the nasal cavity, which are small hollow spaces, in the bones of the head surrounding the nose. This area is formed by the hard palate inferiorly, the cribriform plate superiorly, and the mucosal folds laterally. The nasal cavity filters, warms, and humidifies inspired air. It traps odor-bearing particles for olfaction, and it provides drainage of the paranasal sinuses located in those hollow spaces of the facial bones surrounding the nose. The paranasal sinuses are paired frontal, maxillary, ethmoid, and sphenoid sinuses that, just like mentioned, surround the nasal cavity. The various functions of the paranasal sinuses include lightening the weight of the head, humidifying and heating inhaled air, and increasing the resonance for speech, and it serves as a crumple zone to protect vital structures in the event of any facial trauma. Lastly are the salivary glands, which are the major glands on the floor of the mouth and near the jawbone, which function in producing saliva. And there are three major glands. The first being the parotid glands, which are the largest, and they are located in front of the ears. The saliva produced in these glands is secreted into the mouth from a duct near your upper second molar. Next are the submandibular glands, which are the size of a walnut and are located below the jaw. The saliva produced in these glands is secreted into the mouth from under the tongue. And lastly are the sublingual glands, which are the smallest of the major salivary glands. These are almond-shaped structures located under the floor of the mouth and below either side of the tongue. So if cancer within the head and neck region is going to spread, it almost always does so locally into the lymph nodes of the head and neck. Some cancer cells can be found in the lymph nodes of the upper neck when there's no evidence of cancer in other parts of the head and neck, and that's possibly because the primary tumor is too small. The lymph nodes in the cervical region are important to mention because they are usually involved in surgery through dissection, and they can have a direct effect on post-operative symptoms such as lymphedema, which we will get into later on in this presentation. These lymph nodes are located on either side of the neck within fibroadipose tissue, along with the internal jugular and the spinal accessory nerve. These nodes process lymphatic fluid that drain from the head and neck structures and enter the venous system at the junction of the internal jugular and subclavian veins. And though the brain, eyes, esophagus, thyroid gland, and skin of the head and neck region are all very close together, they're not classified as regions of the head and neck when speaking of cancer locations. So next I will talk about the histology of head and neck cancer. Head and neck cancers usually begin in squamous cells that line the mucosal surfaces of the head and neck. Squamous cells are thin, flat cells that look like fish scales, which are found in the tissues that form on the surfaces of the skin, the lining of hollow organs of the body, and the passages of the respiratory tract and digestive tracts. These cancers are referred to as squamous cell carcinomas, and they account for about 90% of all head and neck cancers. Some head and neck cancers begin in other types of cells. For example, cancers that begin in glandular cells, such as those of the salivary glands, are called adenocarcinomas and typically account for less than 5% of head and neck cancers. Some examples include mucoepidermoid carcinomas, which are the most frequent primary salivary malignancy, followed by adenoid cystic and actinic cell carcinoma. The other 5% of head and neck cancers includes those of melanomas, soft tissue tumors, and lymphomas. So before we get into the nitty-gritty here, let's talk some numbers. Head and neck cancers account for 4% of all cancers in the US. More specifically, it is 2 times as common in men than in women. This year, an estimated 66,000 people, of that 48,000 men and around 18,000 women, will unfortunately develop head and neck cancer. Besides being twice as likely if you are male, it has been shown to be more common in those greater than 50 years of age. Head and neck cancers account for about 1.8% of all cancer-related deaths. More specifically, it was estimated around 14,000 deaths from head and neck cancer, again, will unfortunately occur this year. As for the new cases that occurred in 2021, it was around 54,000. Most of those have been diagnosed with mouth, throat, or voice box cancer. Paranasal sinus and nasal cavity cancer and salivary gland cancer are much less common. So oral and pharynx cancer represents about 2.8% of all new cancers in the US. Because oral and pharynx cancer make up such a big percentage when compared to the other types of head and neck cancer, I wanted to show you this chart from the National Cancer Institute that gives you a visual. The darker blue represents males, and the lighter blue represents females. And this is based off of 2014 to 2018 data. So you can see here that oral and pharynx cancer are much more prevalent in males, especially those of Caucasian and non-Hispanic backgrounds. So many head and neck cancers manifest as silent tumors, which are having symptoms until the tumors reach more advanced stages. For these slides, I wanted to break down the symptoms of head and neck cancer based on each location, some areas overlapping with similar symptoms, being that they are so closely related. So common symptoms for the oral cavity can include white or red patches on the gums, the tongue, or the lining of the mouth. They can have a growth or swelling of the jaw that causes the dentures to fit poorly, become uncomfortable, or they could have unusual bleeding or pain in the mouth. Common symptoms for the pharynx as a whole include a lump in the neck or throat, nosebleeds, ringing or buzzing of the ears, headache, persistent sore throat, difficulty or pain when swallowing, hoarseness, referred ear pain, or diminished hearing. Symptoms of the larynx can include a lump in the neck, pain when swallowing, ear pain, trouble breathing or speaking, again, hoarseness, difficulty swallowing, hemoptysis, or stridor. Continuing on here, some paranasal sinus and nasal cavity symptoms could be sinuses that are blocked and do not clear, chronic sinus infections that do not respond to treatment with antibiotics, bleeding through the nose, frequent headaches, swelling or trouble around the eyes, pain in the upper teeth, or problems with dentures. For the salivary glands, symptoms can include swelling under the chin or the jawbone, numbness or paralysis of the facial muscles, or pain in the face, the chin, or the neck that does not go away. And then lastly, for the regions of the neck, we're specifically talking about swelling of the lymph nodes. So now I would like to address what can increase someone's risk for getting head and neck cancer. I kept this slide as a general list versus specifics for each region of head and neck cancer because that list could be very long. So starting with, as I mentioned earlier, certain demographics are at a higher risk, specifically those above 50 years in age, men versus females with that 2-to-1 ratio, and African Americans are at a higher risk as a whole. To no one's surprise, 75% of head and neck cancer is caused by tobacco, whether it's smoking, chewing tobacco, or secondhand smoke, as well as alcohol consumption. The combination of alcohol and tobacco is 100 times higher than single use alone. It has been found that avoiding oral HPV infection can reduce the risk of associated head and neck cancers, specifically for oral pharyngeal cancers involving the tonsils or the base of the tongue. Certain genetics can increase someone's risk for developing head and neck cancer. And I'm focusing on 2 specific disorders. The first being Fanconi anemia, which is a rare genetic disease resulting in impaired response to DNA damage. People with this syndrome often have blood problems at an early age, which may lead to leukemia or myelodysplastic syndrome. And they also have a very high risk of cancers of the mouth or throat. Dyskeratosis congenita is a genetic syndrome that can cause aplastic anemia, skin changes, and abnormal fingernails and toenails. People with this syndrome also have a high risk of developing head and neck cancers, especially of the mouth and throat, at a very young age. Pan and gutka originated in Southeast Asia, and they're typically chewed for their stimulant effects. They are strongly associated with an increased risk for oral cancer. Preserved or salted foods in high quantities, more specifically during childhood, is a risk factor for nasopharyngeal cancer. As we know, oral health is very important. So poor hygiene, ill-fitting bridge work, broken or missing teeth, mucosa irritated by jagged teeth can all increase someone's risk for developing oral cancer. Certain occupational exposures can increase someone's risk. Specifically, wood dust can increase the risk for nasopharyngeal cancer. Certain industrial exposures, such as asbestos and synthetic fibers, have been associated with cancers of the larynx. And wood, nickel dust, or formaldehyde is a risk factor for paranasal sinus and nasal cavity cancer. And radiation to the head and neck region for non-cancerous conditions or other cancers can increase someone's risk for salivary gland cancer. And lastly, the Epstein-Barr virus can increase the risk for nasopharyngeal cancer and cancer of the salivary glands. So I want just to briefly touch on prognosis of head and neck cancer. Obviously, it is dependent on the location, the stage, and if metastasis has occurred. I found this article focusing on specific locations, and it helped to break down the survival rate at 1 year and then 5 years and beyond. As expected, across the board, the survival rate decreases the longer out you are with the cancer, with hypopharyngeal cancer having the lowest survival rate at 5 years. Comorbidities and other risk factors, such as continued alcohol or tobacco use, will adversely affect the prognosis as well. And it's important to note that head and neck cancer is lacking in studies when compared to breast or lung, so the data regarding prognosis is constantly evolving. I'm now going to pass it over to Helene for the next part of our lecture. Bear with us as we're just changing our screens here.
Good morning, everyone. I'm actually coming to everyone from work. While I get my presentation up, I think we're actually all just curious who's in the audience and where everyone's from. So if you feel so inclined in the chat, if you want to share where you're from or a little bit about where you work, we're just curious who we're talking to. So while you guys do that, I'm just going to pull up my slides. Can everyone see? Okay, great. So yes, thank you to Janelle for a great introduction to head and neck cancer. But switching gears, I'm going to be talking about the screening and diagnostic process for head and neck cancers in general, and then followed by a discussion about treatments for many of the specific cancers. So Janelle discussed the symptoms that patients present with. Either a medical doctor or a dentist, especially if the symptoms are in the oral cavity, will examine the areas. So the doctor or dentist will feel the inside of the mouth with gloved hands, checking the insides of the cheeks and lips, the gums, the roof of the mouth, top, bottom, sides of the tongue. And the doctors will also feel for swollen lymph nodes and look for lumps or other lesions. And if lesions are seen, for example, in the oral cavity, certain staining procedures such as fluorescence staining or exfoliative cytology or a brush biopsy may be used to find any abnormal tissues that might become cancer. If warranted, the doctors may perform a neurological exam, taking a look at the patient's mental status, their coordination, and getting an idea of just how well the muscles, senses, and reflexes are working in the head and neck region. And then after a physical exam, certain imaging might be indicated, including a CT scan, an MRI, a PET scan, an ultrasound, blood chemistry studies, or a CBC. And then there's also a number of head and neck specific diagnostic procedures that might be completed if someone's suspected to have cancer in that region. So certain cancers such as nasopharyngeal cancer and oropharyngeal cancers may be caused by HPV, so a lab test may check for HPV infection. The Epstein-Barr virus has also been linked to nasopharyngeal cancer, so sometimes blood tests checking for EBV antibodies or EBV DNA are completed. An endoscopy is a procedure used to look at areas in the throat that can't be seen with the mirror during the physical exam. So during an endoscopy, a thin tube is inserted through the nose or the mouth to check for anything that seems unusual. Tissue samples are then taken for biopsy. And although not considered part of the head and neck region, sometimes workup for head and neck cancer may require imaging of the esophagus. So a barium esophagogram is an X-ray of the esophagus that involves the patient drinking a liquid containing barium that coats the esophagus while the X-rays are taken. A laryngoscopy looks at the insides of the throat and larynx or voice box, while a nasoscopy is done to look through the nose. Give me 1 second. I'm trying to advance my slides. Let's see. There we go. So in terms of specific treatment, I'm going to be going through the most effective treatments for each of the specific groups of head and neck cancer. But in general, as with most, if not all cancers, treatment can be varied based on the specific diagnosis, the location of the tumor, the stage of diagnosis, and the patient's age and general health. So a lot of the next few slides are going to look very similar, and that's because they are, and they're also a little dry, so just bear with me. I promise it's going to get exciting. But generally, treatment for head and neck cancers can include some combination of radiation or surgery and or chemotherapy, and it can also include immunotherapy, which I'll talk a little bit more about later. So when it comes to lip and oral cavity cancer, Surgery and radiation can each be considered alone or in combination, depending on the site and the size of the primary tumor, as well as the status of the cancer and the lymph nodes. Early cancers, so those diagnosed at stage 1 and stage 2, are highly curable either by surgery or radiation alone, the choice of which is often based on possible functional or cosmetic results. For lesions in the oral cavity, a surgical resection must remove all of the gross and also the presumed microscopic extent of the disease. And if regional lymph nodes are positive, cervical node dissection is usually done together with a wide local excision. And if needed, plastic reconstruction surgery is also done to achieve necessary functional results. And then if radiation therapy is needed, either external beam radiation therapy, interstitial implantation, or both are used. Smaller lesions can usually be treated by intraoral cone radiation therapy, but larger lesions are usually managed by external beam radiation to target both the primary site and the regional lymph nodes. Moving on to hypopharyngeal cancer, I will start by saying that patients with cancer in this region do have some of the lowest survival rates of all cancers in the head and neck. The reason for this is because symptoms usually don't appear until later in the course of the disease. For hypopharyngeal cancer, there's no singular treatment regimen that provides an advantage over any other regimen. Some very early stage hypopharyngeal cancers have been successfully treated with radiation alone, but most treatment regimens include surgery first, followed by post-operative radiation therapy. Surgeries can include a laryngopharyngectomy, which is surgery to remove the larynx and part of the pharynx, or a partial laryngopharyngectomy, which preserves the voice. If cancer has spread to lymph nodes or other tissues of the neck, a neck dissection might be warranted. Excuse me. In some advanced presentations of hypopharyngeal cancers, adding the use of neoadjuvant chemotherapy may increase the chance for local control. Neoadjuvant chemotherapy is chemotherapy given as a first step to shrink a tumor before the main treatment, which is either radiation or surgery. And as it'll come up a few more times in this lecture, I just wanted to review that chemotherapy given at the same time as surgery or radiation is known as concurrent chemotherapy. And when given after surgery or radiation, it's referred to as adjuvant chemotherapy. Switching gears now to nasopharyngeal cancer. Again, there's no true standard treatment. And as mentioned earlier, treatment truly depends on the specific diagnosis, the stage at which cancer is discovered, the location of the tumor, and the patient's overall health. Treatment can include either radiation therapy alone, concurrent chemoradiation followed by adjuvant chemotherapy, neoadjuvant chemotherapy followed by concurrent chemoradiation, or surgery for residual nodal disease, or chemotherapy for metastatic disease alone. So I know that's a lot of different choices and orders, but usually the treatment for the primary tumor site is high-dose radiation therapy with chemotherapy. And this is also used for the neck if the cancer has progressed. Surgery for nasopharyngeal cancer is usually reserved for lymph nodes that fail to respond to radiation therapy or can be used for nodal recurrence after an initial complete response. For oropharyngeal cancer, there's also no optimal approach to treatment because, again, no single regimen seems to offer a superior chance of survival than any other regimen. For patients with early stage disease, a single modality treatment is preferred. Historically, radiation alone is used, but the use of transoral surgery is increasing. For patients with stage 3 or 4 oropharyngeal cancers, surgery followed by post-operative radiation therapy may be used, possibly with chemotherapy as well. And I briefly mentioned immunotherapy earlier. So for oropharyngeal cancer, you may see the use of monoclonal antibodies. Monoclonal antibodies, they can identify and target substances on cancer cells that might help the cancer cells grow. Cetuximab is a monoclonal antibody being studied in the treatment of oropharyngeal cancer. Moving right along to laryngeal cancer. So for laryngeal cancer, surgery alone or radiation therapy alone are generally the standard treatment, but again, outcomes from randomized trials observing which might be superior are lacking. For patients with stage 3 and stage 4 laryngeal cancer, concurrent chemoradiation is a standard treatment option. So there's actually a few specific surgeries you might encounter when working with a patient with laryngeal cancer. So I'm just going to go through some of them. A chordectomy is a surgery to remove the vocal cords only. A supraglottic laryngectomy is a surgery to remove the supraglottis only. A hemilaryngectomy is a surgery to remove half of the larynx and it preserves the voice, where a total laryngectomy removes the whole larynx and also involves the creation of a tracheostomy to allow the patient to breathe. And although not considered part of the head and neck region, the thyroid may be removed with a thyroidectomy if cancer has spread to the thyroid glands. So whether or not surgery or radiation therapy is the primary treatment is a multidisciplinary decision. And again, it considers the stage of the disease, the patient's comorbidities, and their functional status. And functional status referring not only to their gross motor mobility, but also voice and swallowing outcomes as well, and the patient's lung capacity. And then cetuximab, the monoclonal antibody I mentioned earlier, is also being studied currently in the treatment of laryngeal cancer. So sometimes the patient presents, excuse me, I'm just going to mute myself for, sorry. So sometimes a patient presents with neck metastases, but they don't have a detectable primary cancer. So in this case, the diagnosis is considered to be metastatic squamous cell neck cancer with an occult primary. These patients should be given the benefit of definitive treatment. Even though there's no discovery of a primary cancer, a number of patients with metastatic squamous cell neck cancer do achieve cure with either surgery or radiation therapy, or a combination of the two. The standard surgical treatment option is a radical neck dissection, which I've mentioned now a few times. I'm going to go into a little bit more detail about in a couple of slides. For radiation therapy, intensity modulated radiation therapy is found to have less short-term and long-term toxicity compared to conventional radiation therapy in terms of xerostomia or dry mouth, acute dysphagia, and skin fibrosis. There we go. For paranasal sinus cancers, the majority of tumors present with advanced disease, and cure rates are generally poor. So that said, the accepted method of treatment is a combination of radiation therapy and surgery. For patients who have operable tumors, radical surgery is generally performed first to remove the bulk of the tumor and to establish drainage of the affected sinuses. And then this is followed by postoperative radiation therapy. And then treatment options also vary based on which sinus the tumors are found in. For salivary gland cancer, high-dose radiation therapy with chemotherapy is a primary treatment. Surgery, again, is usually reserved for nodes that fail to respond after radiation therapy or for nodal recurrence following complete clinical response. So switching gears again, I'm going to go into a little bit more detail about some of the surgeries that are common for head and neck cancers, especially those that may have certain implications for rehab professionals. So this slide here is a thorough but not all-encompassing list of many surgeries you may encounter as you are chart reviewing for any of your patients that are admitted to a head and neck oncology unit. So I'm going to be focusing on the first three: glossectomies, mandibulectomies, and maxillectomies, because these procedures often involve free flaps that dictate a patient's mobility and weight-bearing status following surgery. So a free flap is a piece of a tissue that's disconnected from its original blood supply and then moved a significant distance to be reconnected to a new blood supply. So commonly used free flaps for head and neck cancer that are relevant to post-op mobilization and therefore relevant to us as physical therapists and rehab professionals include flaps from the forearm or thigh and the fibula bone. So a glossectomy is a surgical resection of the tongue. A partial glossectomy is resection of less than 1/3 of the tongue. A hemiglossectomy is resection of 1/3 to 1/2 of the tongue. Subtotal glossectomy is when 1/3 to 3/4 of the tongue is resected. And of course, a total glossectomy is resection of the entire tongue. So again, I chose to highlight glossectomies because the tongue, it plays a very vital role, not only in speech and articulation, but also mastication, oral hygiene, and swallowing. And it's often reconstructed after resection. The goal of reconstruction is to restore function, primarily speaking and swallowing, to as close as normal as possible. The location of the flap donor site is usually from the radial forearm or the anterolateral thigh. And the location dictates the precautions that we as PTs must follow after surgery. A mandibulectomy, which is a surgery to remove all or part of the jaw, may be warranted for treatment of certain oral cavity cancers if cancer affects any part of the jaw. Similar to a glossectomy, when the mandible is removed, it's often reconstructed, but in this case, with a bone from another part of the body. The most common site from which the bone is taken is a fibula. An artery, vein, and soft tissue will also be removed with the bone to assist with revascularization of the surgical site. Patients may also need a skin graft to cover the donor site. So a skin graft is made by taking the top layer of skin from one part of the body and moving it to the surgical site that needs to be covered. If a skin graft is needed, it will be removed from another area, usually the buttock or the thigh. And patients who have a mandibulectomy with reconstruction from the fibula often present to us with a cam boot on that leg, and they may also complain of discomfort at the skin graft site. A maxillectomy is surgery to remove the bones that make up the hard palate or the nasal sinus. And then the space that's left in the roof of the mouth is either addressed with a custom fit obturator or reconstructive surgery. An obturator is essentially like a dental prosthetic. And if reconstruction is done, the most common used sites are the radial forearm, the fibula, or the iliac crest. So my point in really discussing all of this is that something to keep in mind is any physical therapy orders that you receive, whether you're in the acute care setting or an outpatient setting or anywhere in between, you want to make sure that any of the surgeries involving reconstruction from weight-bearing bones, you want to know what the patient's weight-bearing status is. So as I mentioned several times earlier, a neck dissection is a surgery you may see in your patient's charts if their primary head and neck cancer has metastasized to the cervical nodes. The removal of these cervical nodes using a neck dissection is a standard of care for many head and neck cancers. So this really could be a whole lecture in itself, but I'm going to sum it up as best as I can. So a radical neck dissection describes the removal of lateral neck nodes and tissues. In addition to lymph nodes, this operation often includes removing the submandibular gland, the SCM muscle, the jugular vein, and the spinal accessory nerve. Because so much tissue is removed, one side of the neck may appear flatter than the other. And more importantly, because the spinal accessory nerve innervates the trapezius muscle, a radical neck dissection often results in visible drooping of the shoulder and then difficulty raising the arm overhead. An intensive PT program may diminish some of the deficits that follow, but long-term disability can be anticipated. The modified radical neck dissection is currently the gold standard for clinically positive resectable neck disease. For a neck dissection to fall into this modified classification, levels 1 through 5 that you see on the picture here must be removed, and at least one of either the spinal accessory nerve or the SCM or the internal jugular vein must be preserved. So chemotherapy was mentioned as a possible treatment for all of the individual diagnoses that I mentioned earlier, but I did just want to briefly review this meta-analysis of chemotherapy in head and neck cancers. So this study looked at 87 trials comparing local regional treatment to local regional treatment plus chemotherapy. So local regional treatment refers to either radiation or surgery. And this meta-analysis concludes that concurrent chemotherapy was not only more beneficial than just radiation or surgery alone, but also more beneficial than neoadjuvant chemotherapy. Chemotherapy drugs that you may come across in the head and neck cancer population include cisplatin, carboplatin, Taxol, and Taxotere. Cisplatin, Taxol, and Taxotere often lead to peripheral neuropathy, which, as you might know, may impact our patients' proprioception and overall balance and functional mobility. So just make sure you take note if you see any of these chemotherapies in your patient's medical history or current treatment regimens. I'm also going to talk a little bit about radiation. So this slide lists many of the different types of radiation therapy that might be utilized for head and neck cancers. So the first four listed here are types of external beam radiation, which in general is the most common radiation therapy used to treat head and neck cancers. Brachytherapy is a type of internal radiation that involves radioactive material that's implanted in the body. Basically, dozens of tiny seeds containing radioactive iodine are placed at the tumor site with a special needle or catheter. This is occasionally used to treat head and neck cancers that are located in a well-defined region. And then more and more patients now are also being treated with proton therapy. So proton therapy is a type of radiation that uses proton beams instead of photon beams. So unlike photons, protons don't penetrate beyond the tumor and therefore reduce the likelihood of side effects. Because of fewer side effects, proton therapy can be used at a higher radiation dose on the tumor, maximizing the chance of destroying it. And in terms of head and neck cancer, it's mostly used for cancers that have come back after initial treatment. And then finally, I just want to talk a little bit about immunotherapies and targeted therapies that might be utilized for patients with head and neck cancer. So immunotherapy is a hot topic in the oncology world. Essentially, they're drugs that empower the immune system to recognize and fight cancer. In 2016, the FDA approved 2 checkpoint inhibitors specifically for squamous cell head and neck cancer that has stopped responding to standard chemotherapy. These 2 drugs, nivolumab and pembrolizumab, which you may have heard commercials for, Opdivo and Keytruda, they block a protein called PD-1, which is found on immune cells. Usually PD-1 acts like a brake on the immune system, but these PD-1 inhibitors release this brake and then allows the immune system to mount a stronger attack against cancer. And then just a little bit about genomic testing. It's also called tumor sequencing or molecular profiling. It's another type of targeted therapy. It involves looking at cells in a tumor to see if there's any genetic mutations that are linked to the tumor. So at Memorial Sloan Kettering, which is where we work, there's a project called MSK Impact, which has identified a mutation in the PIK3CA gene, and it's found in 13% of head and neck cancers. So now the researchers go on to explore new treatment approaches that are targeting that mutation. So before I pass things over to Jen, I just want to, again, thank you all for being here today. I'm actually at work this morning, so I'm going to be logging off. But again, thank you. Oh, I'm glad to see people answered in the chat. I'm looking forward to reading where everyone's from. Thank you again. And I think Jen put her email if anyone has any questions, so feel free to reach out. Thank you, everyone.
All right, can everyone see and hear the screen? Okay, so Janelle and Helene gave a lot of great background information, but now we're going to get into the actual physical therapy aspect of it. So in our setting where we work in acute care, most patients with head and neck cancer that we see are in the postoperative phase. So I'm going to talk about the typical presentation of postoperative patients and a number of physical therapy considerations. So some precautions, respiratory considerations, the role of communication, the psychological aspect of having head and neck cancer, COVID, of course, postoperative complications, and then also the postoperative pulmonary program and progression of patients. So for the patient with head and neck cancer who's treated surgically, patients without reconstruction are not as complicated. So they may have a trach and drains, but the surgical site is just in the head and neck region, and there's less restrictions and precautions to consider. However, for the patient who needs reconstruction after their surgery, I know that Helene touched on this a little bit, but the reconstruction is usually performed via free flap, which means the tissue is cut away from its blood supply before being transferred. And common areas for free flap are from fibula, from the radius, sometimes from the rectus abdominis, the latissimus dorsi, or an anterolateral thigh graft. I see someone's in the waiting room. I don't know if someone can admit them. I can't see to do that when I'm sharing my screen. So when a patient has reconstruction, this means that the patient has multiple surgical sites, and they'll often have weight-bearing precautions or additional devices such as splints or cam boots. For the non-surgical patient that we see in acute care, the patient may have lymphedema, a feeding tube, or complications from radiation therapy. So this is a general list of different lines and equipment that may be seen post-surgically. So patients often have Jackson-Pratt drains, which I'll show a picture of later on. They'll always have an IV or a Metaport. Sometimes they'll have a PCA, so that's patient-controlled anesthesia, where the patient can push a button to administer themselves a dose of pain medication when they need it. And these patients with flaps often have implantable venous Doppler lines. So these are lines inserted into the flap. It ensures viability and it can detect blood flow. And I'll show a picture of that later as well. Patients usually have a Foley catheter. They may have a cam boot if they had a fibular flap taken. And they may have a wrist splint if they had a radial flap taken. Wound vacs are often used to assist with wound healing. They may have an obturator, as Helene discussed. This is made by a dentist to seal a defect within the mouth. Feeding tubes are very common. So either NG, the nasogastric tube, the percutaneous endoscopic tracheostomy, which is into the small intestines, or the PEG, the percutaneous endoscopic gastrostomy, which is a feeding tube into the stomach. Most of these patients will have a tracheostomy, and almost all of them are on oxygen. So this is a photo of a patient in the hospital who is seen post-op day 2. So you'll see that she's very swollen. She has a trach going into her throat here. She has a splint on her left arm, and she also has an NG tube. So that's that white tube that's going into her nose. These lines can make mobility challenging, and you'll see that from a physical therapy standpoint, we have a lot to work on to help this patient become independent and ready to be discharged home. So this is a little closer view of her. So I want you to see the very large incision that she has coming down her chin and the side of her neck. You can see her trach here and her NG tube again. And here, that blue line going into her neck, we see that implanted Doppler line. So that's going into the flap to help make checking blood flow and viability of the flap easier. The Doppler checks are, the frequency is set by plastics. So right after the surgery, sometimes they're checking the Doppler lines every hour, half hour. And as the patient gets farther from surgery, they'll be checking that less. So this is a better picture of that JP drain, or that Jackson-Pratt drain. And so that's that little grenade-looking drain that's pinned to her gown. So this drain is sutured into her neck, but we have to be careful with all mobility to make sure that there's no pulling on this drain. The patient is not allowed to have the gown tied around the back of her neck, so because we want to avoid any pressure to flaps that the patient may have. So we're always very mindful of the position of all the lines, especially the ones that are pinned to the gown, that we keep them in the correct position when we're mobilizing the patients. And here's a picture of the splint on her arm. So this particular patient had a radial forearm flap. The splint is placed in the OR, as well as the ACE wrap. And as a lymphedema therapist, it's a little, seeing that way the ACE wrap is wrapped is a little disconcerting, but we don't touch that. We don't remove the splint or perform any range of motion to the wrist. The arm can be moved functionally, but we avoid any weight bearing or thorax to the arm. And I want you to note, kind of coming proximally out of that ACE wrap is the wound vac line. You can kind of see the wound vac in the background there. So that's to aid with the wound healing from where they took the flap. So just a few more pictures. On the top left, that's a close-up of her trach. The blue line going up, that's her trach collar. So that's how some supplemental oxygen and humidification being provided there. Top right is a picture of the wound vac on her IV pole. So as we saw, that's connected to her left forearm. The long red item, the bottom right, so that's a red rubber catheter, and that's what we use to suction the trach. And the last picture, bottom left, that's the Doppler, the Cook Doppler machine, and that's what's connected to her Doppler line to ensure blood flow. All right, so here are some considerations that we specifically utilize in our hospital with all post-surgical patients treated for head and neck cancer. So we keep the head of the bed elevated, typically at least 30 degrees. This is often because the patients are on feeding tubes. No ties around the neck, so the gown or the trach collar to avoid pressure to the flap. Often these patients have to keep their head in neutral, or plastics may permit them to turn to one side or the other. No pressure to any of the flap sites. They don't use pillows to keep the head in neutral. And we have to check weight-bearing status for graft sites daily, as well as the ability to lower against gravity. And some of these patients may have a cam boot. So sometimes patients are not allowed to have the leg in a dependent position, even during transfers or walking for the first few days after surgery. So you can see how that might be a little bit of a logistical challenge. You definitely need someone to be holding the patient's leg up all the time, 2 people to help the patient. We're always checking diet orders because these change throughout. We turn off feeding tubes 45 minutes prior to doing any chest PT, and these patients may need suctioning. So any patient with reconstruction has our plastic surgery team involved, and they may give us specific precautions for these patients. But whenever we have a consult for a patient with head and neck cancer who is post-surgical, we follow these precautions. So another precaution that we come across in this population are carotid precautions. So these are for patients with tumors located near the carotids who may be at high risk for carotid rupture. So this is a serious thing. And we don't want to do anything to increase pressure. So we don't do any manual muscle testing, isometric exercise, or Valsalva. We don't take any blood pressure on the side where the tumor is, no neck rotation. And then also the first indication of potential carotid artery rupture may be a slight ooze 24 to 48 hours before the actual hemorrhage. This is called a herald bleed. So we make sure if we see anything like this, we're notifying the medical team. And in the research, I found that rupture of the carotid artery in a patient who has undergone major oncologic head and neck surgery can be between 3 and 4.5%, with incidence increasing as patients have undergone radiation. So thankfully, between us, we've worked with hundreds of patients with head and neck cancer and have never seen a patient have a carotid rupture, but something to keep in mind. So one of the biggest roles that we as physical therapists play with these patients post-operatively is from a respiratory standpoint. So with or without reconstruction, very important to monitor oxygenation throughout all sessions. Patients may have swelling of the upper airways, they may develop pneumonia, they may need supplemental oxygen, or a drop in their SpO2 may mean that they need to be suctioned. Auscultation is very important. I auscultate all of these patients every time I see them. And then although nursing is primarily managing the tracheostomy, it's very important for us to recognize what is normal and what it might look like when it's abnormal. So in our hospital, after a therapist passes a suctioning competency, we can perform all suctioning as needed. So we can perform suctioning of the mouth with a Yankauer device. These patients have a lot of secretions and they may not be able to swallow the secretions in that postoperative period. The most common suctioning that we perform is clean suctioning down the trach, and that's usually with that red rubber catheter that I showed the picture of before. And sterile suctioning is often used in the ICU, and Ballard suctioning is used when a patient's on a ventilator. We have breathing exercise handouts that we give patients on initial evaluation, and in every room they can access breathing exercises on their television in their room. We always review coughing and huffing techniques. We perform chest PT with percussion and vibration when appropriate. We usually don't do postural drainage with these patients just because of their postural restrictions. We have an incentive spirometer with an attachment for the trach, and almost all of these patients are on some kind of humidified air to keep the incisions moist, and then also keep the air humidified for the trach, so the air is not passing through that moist nose and mouth, so the humidification can be helpful. So a little bit more about the tracheostomies. So a tracheotomy is the surgical procedure to make that opening in the trachea, and then the tracheostomy is the resulting stoma through which the tube is placed. And this is very often done during surgeries for patients with head and neck cancer. It ensures adequate ventilation through the upper airway because of that swelling. So prior to working in this setting, I had never worked with a patient with a trach before. It can be a little daunting at first, but management is actually pretty straightforward. And from a physical therapy standpoint, the main thing is to be able to recognize when something is abnormal, to tell the nurse and medical staff, and also to monitor oxygenation and perform suctioning as needed. All right, so communication is definitely something to be taken into consideration for our patients with head and neck cancer. Even patients that haven't had surgery, they may have difficulty being understood due to the side effects of radiation. However, for our patients who are seen post-surgically and have a trach, air goes into the lungs without passing through the voice box, nose, and mouth. So they're usually unable to speak and need to communicate with a whiteboard, gesturing, mouthing words. We want to avoid any large amount of neck rotation. So when nodding yes or no, we always tell our patients to do it really gently because we don't want to impact the surgical site at all. Our good friends from speech therapy and occupational therapy definitely help with the communication aspect of care. And often, while in the hospital, while a patient is stable from a respiratory standpoint, the speech language pathologist will give them a passing mirror valve. So that's a one-way valve. It attaches through the opening of the trach, and it allows air to pass into the trach, but not out. So the air flows up through the vocal cords. So I will say it's very exciting the first time that a patient is able to speak and communicate, and you can hear their voice for the first time. I had a patient who the first thing he said to me after he got his passing mirror valve was that he really wanted to tell me how corny my jokes had been the first few days of seeing him, but it was too much effort to complain about it on the whiteboard. So then he proceeded to tell me this joke, which I thought was great, and I'll share it with you. So a woman walks into the vet with her very limp duck, and she presents it to the vet. The vet pulls out his stethoscope and listens to the bird's chest, and then he shook his head and he said, "I'm sorry, ma'am, your duck is dead." And the woman said, "Are you sure you didn't even do any tests or anything? What if he's just in a coma?" So the vet says, "All right." And he goes out and he brings in a dog. So the dog comes in, it's a Labrador retriever. He sniffs the duck up and down, shakes his head and exits the room. Next to come in is a cat. And the cat comes in and jumps up on the table, nudges the duck a little bit, shakes his head, and then leaves. And the vet turns to the woman and he said, "I'm sorry, ma'am, but your duck is dead." And he turns to his computer and he prints out a bill and it's $500. And she says, $500 for you to tell me that my duck is dead? And the vet says, "Well, if you had just taken my word for it, it would have been $50, but we had to order the lab report and the CAT scan, so it's $500. So the patient told me that joke and that was great. All right, moving on. All right, so post-laryngectomy, a patient may be able to communicate with esophageal speech. So laryngectomy is when the larynx is removed, patient can't create voice anymore. So there's these different modes: esophageal speech, the patient's able to swallow air to create a belching type of speech. Sometimes during surgery or after, a transesophageal puncture can be done. So this creates a communication between the trachea and esophagus, and where a shunt is placed, and the patient can phonate with that. And then also electrolarynx. So that's an electrical device to create a mechanical voice placed in the corner of the mouth, and the patient can sound words that way. So the next thing I want to talk about are some of the psychological considerations and quality of life of patients with head and neck cancer. So some of these surgeries can be extremely disfiguring and have profound side effects affecting quality of life. So just from an acute care standpoint, sometimes we're the first people to take a patient into the bathroom where a mirror might be. So it's very important to make sure the patient is ready to see themselves. Sometimes we hang a towel over the mirror if the patient's not ready. All of us know that we assist patients through some difficult and emotional times, so therapeutic listening is important, and recognizing when a referral to psych or social work may be necessary. But I just wanted to briefly talk about this article called "The Psychological Experience of Living with Head and Neck Cancer, a Systematic Review and Metasynthesis." So it reviewed articles focused on the experience of having head and neck cancer, treatments, and the role of information. So they identified these 6 concepts that are up on the screen. So life is very disrupted, daily disruption, uncertainty and waiting, a diminished self, But this can lead to control, depending on how the patient is viewing their experience and how they're moving forward. So there's a couple of quotes from patients that I just want to read. So the authors talk about the experience of control. So a patient may say something like, but you know, I feel cheated by life. I've worked so hard for everything I have. You have nothing if you don't have health. I feel robbed of the security of knowing I am healthy. I thought this was my time, a time for me. I have lost so much in life, time I can't make up for. And this is versus a patient who may have a different viewpoint and say something like, I value my life and I am really grateful for each day, happy to be alive. I think it is important to put a guilt edge on life and do pleasant things every day. So the article is really speaking about how a patient's support system and specifically the role of the healthcare providers can have in helping the patients have a sense of control and of their viewpoints of how they're dealing with their illness. When we first made this presentation, I thought there was no way I would have to include this slide in here, but here we still are. So a lot of the things that we do with patients in the hospital with head and neck cancer are considered aerosol generating procedures. So chest PT, tracheostomy, suctioning. So it's recommended that high-level respiratory protection be used. So when we're doing any of these things with these patients, or if a patient has a trach, we're wearing an N95, eye protection, we wear a gown. And then also it's very important when we take these patients out in the hallway in the hospital that we're putting masks not only over their mouth, but also over their trach. All right. I want to touch briefly on post-operative complications. So this is from a study by McMahon et al. Investigating post-operative complications after major head and neck cancer. So they looked at 192 patients over 27 months, and they found that 64% of patients had some sort of complication, with 30% of those being serious. So I put in bold the most common complications, and these deal with the wound and with respiratory things. So 38% of patients had wound complications and 29% of patients had pulmonary complications. So as physical therapists, we don't play much of a role with the wound complications, but during the postoperative period, we can play a large role in respiratory complications. So early mobility, education, breathing, coughing techniques, chest PT, encouraging spirometry. And these are all things that we do with our patients postoperatively. So patients in our hospital are generally seen 24 to 48 hours after surgery for a physical therapy evaluation. We get them out of bed, walking if they're able, a respiratory evaluation and intervention, and we determine the appropriate discharge location for these patients, and also a lot of patient education on precautions. So throughout their stay, we do all of these things listed on the screen. But just some very specific exercise considerations that we have. So patients after surgery without reconstruction, we still don't do any range of motion exercises for the upper extremity on the surgical side until after post-op day 7. Patients that are after surgery with reconstruction, we defer all range of motion exercises for the upper extremity on the surgical site for their whole acute care stay. And we have to be aware if the patient, their flap extremity, in terms of exercise, their splint, if they have the cam boot. So we take all of this into consideration. All right, so this is the patient that I showed you some pictures of before, and she had a pretty typical progression within the hospital. So I just wanted to kind of review what she had and how it went. So this was a 66-year-old female. She had right buccal cancer and underwent resection. She had a right lower cheek flap. She had a right modified neck dissection, an abdominal graft site. So where they took that radial flap from, they took a flap from the abdomen to cover that. She had a trach, a left radial free flap, and then also her mental nerve was cut during surgery, so it was repaired during surgery. She was very independent at baseline, and she lived on a farm with her husband. So we saw her post-op day 1 for a physical therapy evaluation. She was a little bit limited by nausea, but she was able to bridge and roll. Post-op day 2, I saw her, and she's doing pretty good. Close supervision with mobility, contact guard for transferring and walking. We did pulmonary thorax and chest PT. Unfortunately, later in that day, she was found to have a right cheek hematoma. So she had to go back to the OR for a hematoma evacuation to avoid potential flap compromise. So she did have one of those post-op complications that are very common, which is a complication to the wound. So post-op day 5, we see her again. She's doing amazing. She's walking in the hallway with close supervision with no assistive device. She's doing stairs. The next day they cap her trach. So that's kind of the first step to being decannulated or having your trach removed. They capped it to see how she does. Post-op day 8, she's essentially independent. She's transferring independently. She's walking. She's doing the stairs. And on that day, they took out her trach. They put her in a full liquid diet, removed the NG tube. And then this is a picture of her on post-op day 9, right before she went home. They did, right after this picture, they removed the JP drains, they removed the Doppler, and she was discharged home, pretty independent. So that's a pretty typical progression of the patient. And so one of the things that I love about working with this population is there's just immense progress throughout their hospital stay. So this patient stayed 9 days, and you could just kind of see how she progressed. She wasn't too bad with mobility in the beginning, but with all the lines and with the trach, mobility was a little bit challenging. In the beginning, she's so swollen, there's so many lines, but by the end, she's decannulated, she's eating, she's independent walking. So immense progress, and physical therapy definitely played a role in her recovery. So before moving on, I just wanted to mention briefly the EDGE outcome measures for head and neck cancer, which can point you in a direction of the best standardized tool to utilize with these patients. You can find a lot more information online as well as some research studies, but I just wanted to mention it here. And so I'm going to hand it over to Jen Miguel, but one more joke. So 2 surgeons are sitting together having lunch and they start laughing hysterically. So a dermatologist walks up and they say, "What is so funny? Why are you laughing so hard?" And the surgeon says, "Oh, you wouldn't get it. It's an inside joke." All right. That's all for me, and passing over to Jen Miguel to talk about a little bit more. There we go.
All right, can everyone hear me and see my screen? All right, everyone can hear me and see my screen? Yeah, okay. All right, perfect. So thanks, Jen, so much for all those jokes. Just wanted to get into some more side effects of head and neck cancer treatment. So along with the physical therapy considerations and precautions just discussed, there are several side effects as a result of head and neck cancer and treatment. We will briefly discuss some side effects that can affect range of motion, jaw mobility, and nutrition. Earlier, Helene mentioned trismus, which often occurs as a result of radiation combined with chemotherapy and/or surgery. Trismus is an uncontrolled inability to open the mouth or jaw and can interfere with daily activities such as chewing and swallowing. It can significantly impact speech, oral hygiene, and nutrition. It can also have psychological implications and impacting one's quality of life. The second is temporomandibular joint disorder, or TMJD, in which patients commonly suffer from restricted mouth opening, stiffness, fatigue, and jaw pain. Signs and symptoms escalate after radiation, with symptoms peaking after 6 months following radiation therapy. Next, forward head and rounded shoulders can occur, leading to impaired cervical range of motion, decreased mouth opening, and pain in the shoulders, neck, and back. Finally, spinal accessory nerve palsy can occur as a result of injury to the nerve during surgical interventions, such as lymph node biopsies or neck dissections. The spinal accessory nerve affects how the sternocleidomastoid and trapezius muscles work. The sternocleidomastoid and rotates the head to the opposite side, and flexes the neck while the trapezius muscles stabilize the scapula and manage shoulder movement, such as shrugging your shoulders. So specific deficits may include a painful shoulder, a rotated scapula due to trapezius muscle paralysis, and loss of range of motion in the shoulder. In the long term, spinal accessory nerve palsy can lead to loss of muscle function, adhesive capsulitis, and rotator cuff impingement. Manual therapy, range of motion exercises, and a strengthening program can help with regaining range of motion throughout the head and neck and increasing strength to improve function and decrease pain. So one side effect that we'll go a little bit more into detail today is facial nerve palsy. So a tumor in the head and neck can present on or near the facial nerve, placing pressure on it as it increases in size. Surgical removal of a tumor close to the facial nerve can also result in the nerve becoming damaged or completely severed. Tumor involvement on the facial nerve can sometimes be mistaken for Bell's palsy. Bell's palsy can occur suddenly without warning over a number of hours. Recovery will usually take place over a period of weeks or months, and patients may regain facial function without surgical treatment. Imaging such as a CT scan or MRI can help diagnose the root cause symptoms. So as previously discussed by Janelle, the parotid gland is the largest salivary gland and found in the front and just below the ear on each side of the face. Tumors can occur in any of the salivary glands, but the parotid glands are the most common location for salivary gland tumors. Parotid tumors often cause swelling in the face or jaw that usually isn't painful. Other symptoms may include numbness, burning, or prickling sensations in the face, or a loss of facial movement. These symptoms are a result of the location of the facial nerve within the body of the parotid gland, dividing the gland into two lobes, superficial and deep, and giving rise to the 5 terminal branches of the facial nerve. So although most parotid tumors are benign, some tumors can become cancerous. Treatment for parotid tumors is usually with surgery to remove the tumor. If the tumor has cancer cells, additional treatments such as chemotherapy and radiation may be recommended. Surgery to remove a tumor in the superficial lobe is called a superficial parotidectomy, and surgery to remove a tumor in the deep lobe or both lobes is called a total parotidectomy. Parotid gland cancers often spread to the lymph nodes in the neck first. Removing the lymph nodes in the neck and other nearby tissue may be done at the same time as the parotidectomy. The goal of this procedure would be to remove the lymph nodes shown to contain or are likely to contain cancer cells in order to reduce the chance of cancer returning in the future. In addition, preserving the facial nerve is an important priority when removing the parotid gland tumor. However, there's a chance that the nerve may be adversely affected by the tumor itself or by the surgical procedure needed to remove the tumor. The facial nerve may be temporarily or very rarely permanently weakened due to tumor removal. The risk of facial nerve weakness is directly related to the size, extent, and type of parotid tumor. So though not technically considered under the umbrella of head and neck cancer diagnoses, we wanted to briefly talk about acoustic neuroma, also known as vestibular schwannoma, and medulloblastoma in relation to facial nerve palsy. These can both lead to damage to the facial nerve and may require facial reanimation surgery and treatment, as we will discuss in the next few slides. Acoustic neuromas are benign tumors that begin in the Schwann cells. Schwann cells create myelin, which is the material that insulates and protects the nerves throughout your body. Acoustic neuromas will often form along the branches of the vestibulocochlear nerve. As an acoustic neuroma grows, it can compress nearby nerves and blood vessels and/or press on the surface of the brainstem and cerebellum. Some side effects include hearing loss, ear fullness, tinnitus or high-pitched tone in your ear, balance impairments, and vertigo. Facial numbness, twitching, or weakness can occur if the tumor becomes quite large. Brain tumors such as medulloblastoma can also cause facial nerve palsy, as it arises very close to the origin of the facial nerve in the brainstem. Compression or surgery in this area can cause facial paralysis. We will be seeing an example of this in our fan case study later on in this presentation. Loss of facial nerve function related to the treatment of a parotid gland tumor can result in partial or total paralysis on one side of the face. As you can see in the picture, the location of the facial nerve branches here, it can greatly impair a person's ability to make basic movements of the face, such as raising your eyebrows, closing your eyes, or smiling. It can be accompanied by vision loss and possibly difficulty with eating or speaking. Highly specialized techniques for treating facial paralysis have been developed so that people can regain these abilities after treatment. By transferring or transplanting muscles and nerves from other parts of the body or rewiring nerves, some movement may be restored within months. This procedure is known as facial reanimation. It may be done when the tumor is being removed or even years later after treatment in some cases. We will be discussing a few of the procedures done at our institution in the next few slides. So first, let's just take a brief look at the facial nerve in order to better understand the functions of each of the 5 branches and their impacts on facial expression. So the frontal or temporal branch innervates the muscles that raise your eyebrows. The zygomatic branch involves closing your eyes. The buccal branch flares your nostrils and raises the corner of the mouth to smile. The marginal mandibular branches cause pouting and frowning, and the cervical branches innervate the platysma, which plays a role in lowering the corner of your mouth. So now that we have an idea of the effects of the facial nerve palsy and the function of the facial nerve, we'll talk a little bit about 6 types of reanimation surgeries. So the first one involves a hypoglossal nerve, which enables tongue movement. In order to restore the resting symmetry or tone of the face, this hypoglossal nerve may be used as a donor nerve. The hypoglossal nerve can be partially cut on its side and connected to the facial nerve to preserve tongue movement. This allows the nerves to grow into the facial nerve without cutting the entire hypoglossal nerve, which is important for speech and swallowing. The second procedure is a mesenteric nerve transfer, which is one of the most common transfer procedures for facial paralysis. The mesenteric nerve supplies the masseter muscle, which elevates the jaw and is one of the muscles responsible for chewing. In this procedure, the mesenteric nerve is rerouted to the injured facial nerve and connected to the buccal branch in order to restore a patient's smile. After about 6 months, patients will be able to smile by biting down and activating the mesenteric nerve. The third procedure is a cross-facial nerve graft, in which an expendable sensory nerve, typically your sural nerve, is harvested and utilized as a graft to connect the facial nerves on both sides of the face. The cross-face graft then guides the regenerating nerve fibers from the healthy facial nerve to the dysfunctional nerve and paralyzed muscles. This procedure is sometimes used as part of a 2-stage reconstruction, where it is the first stage for free muscle transfer, which brings us to muscle transfers. So in general, the gracilis free muscle transfer is used when the duration of facial paralysis is longer than 2 years. In these cases, the facial muscles can no longer receive new input, and a new muscle must be inserted into the face in order to restore smile and facial tone. Commonly, the nerve to gracilis is attached to the mesenteric nerve, and the bite to smile movement is also used here. So when the patient bites down, a smile occurs as a result of this connection. Next, we have the temporalis tendon transfer. The temporalis and bony attachment are cut, and the temporalis tendon and bone are attached to the muscles at the corner of the mouth. This provides improved symmetry at rest and improved speech and eating as a result of the corner of mouth being pulled upwards in a more symmetric position. And finally, we have the dual nerve transfer, which combines 2 of the nerve transfers we discussed earlier, the hypoglossal nerve transfer and the mesenteric nerve transfer. Though the mesenteric nerve transfer can help restore smile, it doesn't always provide sufficient facial tone. And while the hypoglossal nerve transfer can help improve facial symmetry at rest, movement or smile is typically limited. Combining these 2 transfers into one surgery can provide both smile reanimation and restoration of facial tone. So here you can see 2 transfers. So at the top is the mesenteric nerve being rerouted to the facial nerve. In green, we see where the mesenteric nerve is innervating the masseter muscle. This portion here is cut, and the mesenteric nerve is connected here to the buccal branch of the facial nerve. On the bottom, we see that the facial nerve is cut and redirected to the side of the hypoglossal nerve in orange to help preserve tongue movement. Following surgery, patients will usually stay at least overnight in the hospital, but length of stay can depend on the type of procedure the patient had. With the nerve transfers we discussed, patients may be able to go home as early as the following day, but with the chrysalis-free flat muscle transfer, patients will typically stay a little longer. Patients are then referred to physical therapy for facial reanimation therapy following surgeries that incorporate learning how to bite to smile. We'll discuss a few of these exercises involved in reanimation surgery in the last case study. So now sending it back to Janelle, who will discuss lymphedema.
All right. Thank you so much, Jen. Give me one quick second. All right, bear with me. Okay, everyone can hear me, all good? All right, thank you so much, Jen. So switching gears here, I'm now going to, oh, actually I'm a couple slides ahead, I apologize. I'm going to touch briefly on the topic of lymphedema. So I'm not going to be reviewing the entire lymphatic system anatomy and physiology, but I will be touching on the differences between primary and secondary lymphedema. So primary lymphedema is caused by the abnormal development of the lymphatic system, whereas these symptoms occur at birth or later in life. Secondary lymphedema is the most common type of lymphedema, and it occurs primarily when the lymphatic system is damaged by either tumor infiltration or cancer therapy, such as surgical resection of the lymph nodes, vessels, or radiation-induced injuries of the surrounding soft tissues and muscles. So in this case, when speaking about lymphedema caused by head and neck cancer, we are talking about secondary lymphedema. Unfortunately, 75% of patients treated for head and neck cancer will develop secondary lymphedema. And there are two types: external, involving the face and the neck, and internal, involving the oral cavity and the pharynx. So lymphedema is a clinical diagnosis, but there are a number of objective scoring systems that can be used to determine how severe lymphedema is. A common scale used is a Foldy scale, and this is a 5-point scale rating the lymphedema starting at stage 0, which is no swelling, to stage 3, which is irreversible tissue changes with scarring and fibrosis. So these types of scales are for staging of external lymphedema. For internal lymphedema, like Helene mentioned, an endoscopy may be performed to fully visualize and evaluate the severity of the edema within the oral cavity and the pharynx. There are also standardized face and neck measurements that are often used to track progression of lymphedema. These measurements involve different portions of the face and the neck that are used consistently from evaluation to reassessment. Some common complaints that patients with head and neck lymphedema may have are possible difficulty breathing. They may complain that something they feel is stuck in their throat. They may notice voice changes or visual deficits if the swelling is enough to concentrate around the eye. They may have trouble sleeping and overall just decreased quality of life. And that's because of how high the visibility of where the lymphedema is. So the most common and widely accepted treatment method used for lymphedema is called complete decongestive therapy, or CDT. CDT is a series of techniques that involve a form of massage known as manual lymphatic drainage, compression bandaging and clothing with special padding. It focuses on exercises to improve the flow of lymphatic fluid and skin care of the affected areas. CDT has been shown to have lasting effects on the severity of lymphedema at all stages. It's really been shown to improve the quality of life among those with lymphedema. Much of CDT may be performed at home by the patient under the guidance of a lymphedema therapist. And I'll be going over more details of a version of this in one of our case studies. So 60% of patients with head and neck cancer can expect to have a significant improvement post-CDT. And the highest rates of success are seen among patients who consistently and properly use CDT, with a recommendation of at least 5 times a week over a 3-month period. Now, we know sometimes this is not likely, the high frequency for some of our patients, but just know the more frequently performed, the better. Some contraindications for this type of treatment include thyroidism, greater than 50% internal artery blockage, upper quadrant deep vein thrombosis, acute radiation dermatitis, acute cellulitis that has not been treated, acute renal failure, or a history of multiple cerebrovascular accidents or transient ischemic attacks. So I wanted to touch on differential diagnoses for facial swelling. So you know the difference between lymphedema caused by head and neck cancer or something else that could be causing it. The first being superior vena cava syndrome, or SVC syndrome, which is a constellation of symptoms that results from blood flow obstruction from the superior vena cava. The majority of cases are due to underlying malignancy, with non-small cell lung cancer actually being the most common malignancy. Causes can be external compression to the SVC, thromboses, infection, or radiation therapy. Another more common cause of facial edema that we see with our patients is facial cellulitis. This can present with facial swelling due to the infection spreading to the dermis and subcutaneous tissue. Oftentimes, there will be overlying erythema and warmth, and treatment involves antibiotics. Other not so common causes of facial swelling are angioedema, which is subcutaneous swelling resulting from fluid leakage into the interstitial tissue. Submandibular space infection, also known as Ludwig's angina, which is an infection present in the floor of the mouth that has a high risk for decompensation. A mixed edema coma is defined as severe hypothyroidism, and typically this involves diffuse facial swelling. Bilateral periorbital edema and swelling of the lip and or tongue may also be present. Another common cause for facial edema could be a cavernous sinus thrombosis. And then the last two listed here, dental infections and facial trauma, can obviously cause facial edema, but not to be confused with lymphedema from head and neck cancer. So now I'll be getting into our first case study, which is a head and neck lymphedema case. Patient L is a 58-year-old female with HPV negative oropharyngeal squamous cell carcinoma of the right tonsil, which was treated with chemo and radiation. Then, unfortunately, she was diagnosed with recurrent right parotid mucoepidermoid carcinoma. She doesn't have an extensive past medical history. However, it's important to note she's a former smoker that has a history of migraines, hypertension, anxiety, and depression, which will play a role into our treatment plan for her. So she was admitted for a right total paroidectomy and reconstruction with anterior lateral thigh free flap with adjuvant radiation therapy completed later that same year. So her surgery was similar to the case study that Jen reviewed earlier. Her course post-surgery, however, was complicated by right focal cord paralysis and right cranial 12 nerve palsy. She unfortunately also had multiple readmissions for numerous things, including neck pain, adverse reactions to medications. She had new productive cough, difficulty swallowing. So rather than look at one point in time, this case study will look at multiple readmissions to give you a clearer picture of her overall postoperative recovery, specifically looking at her lymphedema symptoms and progression with treatment. So in general, the symptoms that patient L had were lockjaw, difficulty swallowing, pain when swallowing, voice changes. She had right-sided ear pain, decreased tongue mobility, right-sided facial weakness and paresthesia, and right-sided facial and neck lymphedema, which is why we were consulted. The lymphedema symptoms that patient L had were obviously swelling, achiness, heaviness, fatigue, tightness of the skin, just an overall discomfort. All were worse when supine and first thing in the morning after laying flat while sleeping. The onset of her lymphedema symptoms, they were mild after her initial surgery. However, they did increase after she had radiation therapy. So when we first evaluated her for lymphedema, her stage of lymphedema, according to the scale that we use at our hospital, was considered to be stage 2A, which is considered to be spontaneously irreversible. It involved pitting edema of the skin and tissue fibrosis, and her edema was always present. I mentioned earlier there are multiple scales that are used to stage patients' lymphedema. We use a modified version of that Foldy scale that I described earlier, which is developed by the International Society of Lymphology. The location of her edema was on the right side of her face and neck. However, it was more prominent around her right jaw and upper neck. The tissue condition was soft around the face and inferior eye and more firm around the jaw and upper neck. You can see in this picture here, her scar and some of the tissue fibrosis from the radiation along her jawline. For facial mobility, she was unable to completely close the right eye initially. However, she did report improvements over time. And for jaw mobility, she had about 2 fingers width for opening. However, she was able to eat normally. And she did have some right-sided mouth droop due to the facial nerve palsy. So before I get into our initial evaluations, I want to show you what exactly we measure on patients with head and neck lymphedema. These are 7 objective measurements, which allow us to pinpoint exactly how swollen a patient is on a certain aspect of their face. These measurements are performed on both sides to compare laterality, and they are used at the time of our initial evaluation and reassessment to hopefully show progress made over time. Starting with the tragus to the mental protuberance, then we measure the tragus to the mouth angle, followed by the mandibular angle to the nasal wing. Then we look at the mandibular angle to the internal corner of the eye, and then the external corner of the eye from that same starting point. We then look at the mental protuberance to the internal corner of the eye, and then the mandibular angle to the mental protuberance. Sometimes, if there's a lot of neck swelling, we can also do circumferential measurements of the neck as well. So I know this slide has a lot of information on it. What I want you to take from this slide is the progress made from our initial evaluation to our most recent initial evaluation. I mentioned earlier those multiple readmissions. So instead of showing you initial evaluation to reassessment, it's more useful to show you admission compared to readmission. As you can see, her measurements decrease over time, meaning her lymphedema has minimized. You can see for the tragus to the mental protuberance measurement, her numbers decrease from 15 centimeters initially to 13.5 centimeters on that right side. And the same for the mandibular angle to the internal and external corners of the eye, and so forth. And it's important to note that these 3 admissions were not the only time she was seen for lymphedema therapy. She's very familiar with our outpatient therapy services, and she's very dedicated to her home exercise program, which I will talk to you about on this next slide. So her treatment involved every aspect of complete decongestive therapy. We focused a lot on manual lymphatic drainage for her treatment sessions while inpatient. I won't get into the specifics, but as you can see here from my not so artistic picture of a human face, it involves pushing the fluid towards the intact lymph nodes away from the areas of fluid concentration. And you can see the general flow of fluid mobilization from the arrows shown here. So I mentioned earlier, she's a past medical history of anxiety and depression, which obviously was worsened due to her lymphedema symptoms and postoperative complications with her multiple readmissions. So I feel that besides the MLD really helping with the fluid mobilization, it helps her just to relax and feel better overall. For bandaging, we focused on an overhead compression bandaging technique that we used one of our smaller bandages for, and it was applied in a figure 8 pattern. So it was tracing over her head and under her chin to help compressing the fluid, and more specifically in her right jaw and cheek area. For skincare, we focused on good hygiene, using moisturizer to help keep the skin and well intact. And the patient performed also some different active range of motion exercises and stretches to help improve myofascial mobility and to enhance the lymphatic drainage of the head and neck. Some examples included neck extension stretches, levator scapulae stretches toward the left side, chin tucks with a focus on cervical retraction, and some postural alignment exercises as well. So on her initial admissions, our frequency was a little bit higher, around 3 times a week. However, as time moved on with her more recent admissions, we decreased our frequency to 2 times a week. And this is due to her high compliance, like I said, with her home exercise program, including the manual lymphatic drainage and the bandaging, and due to her significant improvement in her symptoms over time. So like I mentioned earlier, we recommended continued follow-up in outpatient as needed initially. And then on her most recent admission, we recommended no further services after she were to be discharged from our hospital. And that's because she really progressed well and again was so independent with her home exercise program. So these are a few of her treatment material used when bandaging. The picture on the left is showing foam with striations for helping to break down the fibrous tissue and improve her skin mobility. This would be going underneath the bandages on the area of her right jaw and cheek. And then for the picture on the right, the left corner, you will see a blue square, which is called Dysum, which she used for helping to stretch the skin for scar mobilization purposes. This is focused on more in the outpatient setting. However, it's still important to mention. Below that blue square is this chip pack, which is small pieces of foam held together. This she also used for the fibrous scar tissue to help break up adhesions to go underneath the bandages, which you will also see shown here to the right of that. It's a smaller bandage and one that's a little bit larger. So next, we will be focusing on a complex head and neck surgery case. So patient N is a 54-year-old female with a history of spindle cell sclerosing rhabdomyosarcoma, with recent imaging showing progression of disease in the right superior and medial orbital walls, the frontal sinus, and the ethmoid and nasolacrimal duct. For her past medical history, I listed anxiety first because, like we talked about, this can play a significant role in the healing process and overall quality of life for these patients. A lot of the patients we see who have head and neck cancer, like the last case study, have anxiety listed in their past medical history, understandably so. And for her, this is followed by hyperlipidemia, ulcerative colitis, and ethmoidectomy. And she was admitted for a joint craniofacial reconstruction with tumor resection. So I know our presentation is focusing on head and neck cancer. However, besides the head and neck surgery team, 3 other medical teams were involved in her surgery, making it to be very complex. The head and neck surgery team performed the tumor resection and reconstruction using the nasoseptal flap. The neurosurgery team performed a bifrontal craniotomy and harvesting of the pericranial and capillary grafts for reconstruction of the frontal sinus. They were also involved with placement of the lumbar drain. The ophthalmology team helped with exposure of the right medial superior orbital wall with the tumor resection, while sacrificing the right cranial forenerve and the superior oblique muscle. And then lastly, the plastic surgery team was involved, and they focused on the free flap from the left arm for the right orbital and facial reconstruction. So now after all of that was completed and the patient was medically stable, that's when they send in the rehab team. So before I get into specific details of the patient's progression while at the hospital, I wanted just to show you an overview of the patient's length of stay. As complex of a medical procedure as it was, the patient was referred to PT on only post-op day 3 and was discharged from the hospital on post-op day 6. So she wasn't even in the hospital for a full week. It really is amazing how quickly she progressed and how well she did post-operatively. So getting into that, like I said, she was referred to PT on post-op day 3. However, we saw her for PT for the evaluation on post-op day 4. Some important things to note from the initial evaluation. She lived in an apartment with no steps to enter or within the home, and she had great family support, which made it easy when it came time to discharge. Her prior functional status, she was fully independent. She reported being fairly active prior to her admission, even throughout all of the chemo and radiation, and this really helped her to get on her feet and back out the door. Continuing with the PT evaluation, as the PT, we had a lot of things to keep in the back of our mind when going to mobilize her. First being all of her precautions. With the extent of her surgery, she was a high safety and falls risk. We had cardiac parameters of 50 to 130 for heart rate and systolic blood pressure of 100 to 170. So making sure her vital signs were within those ranges throughout all of mobilization. She also had head and neck precautions, and Jen reviewed these earlier, but to refresh your memory, she had to keep her head and neck in a neutral position at all times. She was not allowed to turn her head, and she was not allowed to have any pillows behind her neck that would put her into any cervical flexion. No ties were allowed around the neck. So for example, like the hospital gown, and no pressure to the graft sites. She also had craniotomy precautions. So these involved no bending forward, keeping her head above her heart, no heavy lifting, avoiding the Valsalva maneuver, no resistive or isometric exercises. So really avoiding anything that would increase her intracranial pressure. She also had to maintain her head of the bed at greater than 30 degrees, and this was just until the doctor gave her clearance to lay flat. And then lastly, she had to maintain her left upper extremity non-weight bearing, being that it was a graft site location and she was splinted. She had no weight bearing restrictions for the left lower extremity though. She was able to fully weight bear. So on top of her precautions, she had numerous lines we needed to manage and be careful with when mobilizing her. She had a Metaport, she was on telemetry, and she had a wound back to the left forearm, along with the lumbar drain. So with close monitoring of her vital signs and the line management, we were able to do our assessment. This chart shows her range of motion, which was within normal limits for both her lower extremities and her right upper extremity. The left upper extremity, the shoulder and elbow was within normal limits, but we couldn't assess the left upper extremity further, being that it was a splinted and it was the graft site location. For the manual muscle test, we were not able to assess this formally because the resistance, if we were to apply it, could put her at risk for increasing her intracranial pressure, which therefore would break her craniotomy precautions. However, functionally, we were able to see that she was at least 3 out of 5 for her upper extremities and lower extremities. And in terms of her functional mobility assessment, she was able to, she got min assist across the board. She was able to perform bed mobility with MinAssist. She was able to transfer with MinAssist. And she was also able to transfer from bed to chair with MinAssist and handheld assist that we provided her. So when we had her get from bed to chair, we noticed that she wouldn't have been able to do it without some sort of external support. So that kind of helped us think, what we would need to mobilize her next. So based off of our evaluation, we determined that she would benefit from a frequency of 3 times a week for physical therapy. And it's also important to note she was getting occupational therapy 3 times a week as well while in the hospital. And then for our discharge recommendation, we recommended home physical therapy services, knowing she had no barriers of stairs to enter or within her home, and she had great family support to assist her as well. So on post-op day 5, our follow-up session, she made significant progress. She was performing bed mobility with supervision. She still required MinAssist for transfers. However, she was able to progress to gait training at this session. I mentioned on the previous slide, we noted she needed some sort of external support when standing. So we brought a standard cane for this follow-up session. Remember, we couldn't trial a rolling walker because the left upper extremity was splinted and non-weight bearing. So on this session, she ambulated 30 feet times 3 with the standard cane. However, she still was not as steady as we would have liked, which brings us to our last follow-up session, the day of discharge. So we were able to trial a narrow-based quad cane to give her a little bit more support. And she was able to ambulate almost 100 feet with that narrow-based quad cane with supervision. Like I said, on this day, she was discharged home with the quad cane and home physical therapy services. So one last thing to mention, I stated earlier she had a lot of anxiety. So a good portion of our treatment sessions incorporated relaxation techniques, for example, deep breathing, which was good for her pulmonary hygiene as well. And it really helps to facilitate a better session. Sometimes we also played music during her treatment sessions to help kind of lift her spirits and to help motivate her. And she really did excellent. She was very happy to go home so soon. And now I will pass it over to Jen Miguel for our last case study of the presentation.
All right, guys, everyone can hear me? All right, so we're wrapping up onto the final case study. This final case discusses facial reanimation. So though our lecture was primarily based in acute care, we just wanted to transition to an outpatient case as patients would transition from inpatient care to an outpatient setting following facial reanimation surgeries. So patient I is a 14-year-old male who initially presented with left-sided facial paralysis. He was found to have a medulloblastoma. He had his tumor resected about a month later, followed by chemotherapy and proton beam irradiation. Following surgery, he developed complete right facial paralysis that lasted about a week, resolving somewhat, but still presenting with mild to moderate weakness on the right side and complete left facial paralysis. In addition, he presented with left-sided weakness, gait impairments, and decreased balance, requiring the use of both lower extremity orthotics, and he received outpatient therapy after surgery in order to address these impairments. 2 years following the surgery, he had a needle EMG that showed no motor activity in the left face and some moderate abnormalities on the right side. There were still viable motor end plates in the left orbicularis oculi, which assists in eye closure, and zygomaticus major, which helps with smiling. So these are here. And then on his presentation prior to surgery about 8 months later, he showed no brow elevation, eye closure, or smile. He also continued to have no facial motion after more than 2 years of paralysis. Having deficits in both the left and right face contributed to challenges in choosing the best facial reanimation surgery for this patient. The surgeon decided on a dual nerve transfer, which we spoke about earlier, in which he performed a nerve to masseter transfer to the upper division of the facial nerve and mini hypoglossal end to side transfer to the lower division of the facial nerve. He discussed with the patient that this type of reanimation surgery would require you to bite down to smile and close his eyes, and he would require rehabilitation following the surgery to help retrain and regain function of his facial muscles. During this patient's 3.5-month post-surgical follow-up, he showed subtle but clearly present excursion of levator labii superioris, which elevates your upper lip, and some zygomatic major, which pulls your mouth superior laterally, and oculi muscles, which assist in eye closure. There were definite signs of reanimation from the nerve to masseter. The surgeon instructed the patient to perform clenching exercises using a bite guard to be completed 2 to 3 times daily with 20 repetitions each. The surgeon then reinitiated a referral to outpatient PT for facial reanimation therapy, and we saw this patient about a month after his follow-up, which was about 4 months after his surgery. So on initial evaluation, the patient reported that it took a little longer for him to chew, and he had to eat slowly, but was able to chew soft foods on both sides. He had difficulty chewing tougher foods like steak, but was able to eat chips and pretzels. He stated that he had some trouble with controlling mouth closure, but had no spillage of water when drinking. He reported no difficulty with speaking, but it was occasionally difficult to understand the patient during the evaluation. He reported no difficulty with brushing his teeth. So we utilized this movement scale here on the right side to help grade facial animation on evaluation and during each reevaluation. The patient exhibited a little less than 25% of left eye closure and less than a quarter of the range of smiling, noting some right-sided excursion upon return. There was slight movement noted during puckering, pouting, and frowning. He presented with forward head posture and forward rounded shoulders in both sitting and standing. He had decreased lumbar lordosis with minimal increase in hip flexion and standing, and ambulated with a wide base of support and toe out gait, requiring the use of bilateral SMOs or supramalleolar orthoses. Though he did not utilize an assistive device, he required at least supervision for all mobility due to his gait and balance impairments, as well as having a history of falls. He reported eye tearing and requiring increased time with eating certain foods, in addition to the impacts on his social life, which we'll see in the facial disability index soon. He also presented with synkinesis, which is unwanted contractions of the muscles of the face during attempted movements. We will discuss this a little bit more on the next slide, where we'll look at physical impairments. So seen here is a Sunnybrook facial grading system, which measures resting symmetry, symmetry of voluntary movements, and synkinesis. An example of synkinesis would be muscle spasms or forceful eye closure when a patient is attempting to smile. The composite score ranges from 0, which is complete facial paralysis, to 100, being normal function. As you can see here, the patient showed slight movement in gentle eye closure, smiling, and lip puckering, but exhibited synkinesis when attempting to smile, snarl, or pucker his lips. After doing some math, you can see that he scored a 19 out of 100 on his evaluation. Next, we have the Facial Disability Index. This is a self-report designed to provide information on a patient with a facial disorder and their related social and emotional well-being. The FDI has 10 total questions, 5 related to physical function, seen here, and 5 related to social function, as we'll see in the next slide. The highest score you can achieve in each section is 100, with a total FDI score of 200 when combined when utilizing the scale on the right side here. The patient reported some difficulty with keeping food in his mouth, moving food around, and getting food stuck in his cheek. He reported no difficulty with drinking from a cup, saying specific sounds while speaking, or oral hygiene, and much difficulty with eyes tearing excessively or becoming dry. He scored a total of 75 out of 100 on physical function. In terms of social function, he reported feeling calm and peaceful some of the time, and waking up early or several times during the night none of the time. He reported isolation from other people and getting irritable around others a little bit of the time. He also indicated that his facial function kept him from going out and participating in family or social activities a little bit of the time. He scored an 80 out of 100 in social function, bringing him to a total score of 155 out of 200 on the FDI. So here we can see a progression of smiling, beginning with 4 months after initial evaluation, up to about 2 years later. Most notable is a more pronounced nasolabial fold and an increase in the corner of his mouth being pulled up and out when attempting to a big smile over time. In addition to improvements in his smile, the patient was able to achieve intermittent eye closure after about 1 year and 8 months, and full eye closure about 2 years later. So some of the interventions utilized included addressing his postural deficits and incorporating active neck range of motion. The biggest part of facial reanimation therapy in the beginning is neuromuscular re-education. I spoke earlier about the movement of biting down in order to bruise the smile after some of the facial reanimation surgeries. The primary focus initially is teaching the patient these exercises and incorporating unilateral and bilateral clenching, followed by raising the lip in order to try to produce a smile. We also utilize biting down when attempting eye closure. As the patient shows improved control, incorporating graded smiles like small, medium, and large smiles, and working on gentle eye closure would be good progressions of these movements. Other exercises include tongue thrusting at the roof of your mouth, lip puckering or making a fish face, pouting, and frowning. Tactile cues and assistance into these motions can be provided. And use of a mirror for visual feedback helps the patient see the movements and tune into their posture, adjusting as needed. Finally, neck stretches and myofascial release were also incorporated for this patient on both sides of the face to assist with improvements in overall function and facial movements. This patient was initially seen for 2 times a month and progressed to 1 time a week as the patient showed more progression following manual therapy during his treatment when it was appropriate. Upon a reevaluation about 2 years later, the patient had no difficulty with eating and was able to chew all textures and move food between both sides easier. He reported no spillage of water when drinking or difficulty with mouth closure. His speaking was intact and had no trouble with oral hygiene. He was able to achieve 100% of left eye closure with increased consistency. He achieved half to 3/4 of the range of a full smile, but now with synkinesis to orbicularis oculi, exhibiting a little bit more of the eye closure with it. He presented with 1/4 to half range of puckering, slight movement with pouting, and 1/4 of the range with frowning. And on the Sunnybrook, he achieved a 38 out of 100 compared to 19 out of 100 on initial eval. And on the FDI, he scored a 95 on physical function and a 96 on social function, achieving a total of 191 out of 200 compared to 155 out of 200 on initial eval. At the time of this presentation that we spoke, he continued to receive the outpatient PT services and was progressing pretty well each day. So this concludes our presentation. Again, Jen had put her email in our chat box, so we just wanted to offer up that if anyone had any questions, you can email us or send us a message on the chat box.
Thank you so much for your presentations. They were just so good because they were comprehensive. They hit not just functional mobility and the lymphedema, but they also talked about teamwork with the other members in the healthcare arena on these patients, as well as the mental health concepts, which are so important. So I applaud you and I thank you again for presenting this, because I think this is so important globally to know this information. I did post something in the chat area, and I'm asking people if you would put some information in there about what you found that was most helpful for you in your region, and let us know what your region or country is. And then, if you're going to incorporate that into your practice. Also for networking purposes, if you could post something in there about what treatments you're using in your area that may be different than what were explained today, but they work well in the population that you're dealing with. And this is a great way for us to learn what's going on. We can take a few comments, and I particularly want to hear from, people that are possibly doing research or other types of treatment management of patients in their area. So if you would like to comment, please raise your hand, push your hand button on the item, and then Anne can unmute you and we can let you contribute to the conversation. So any comments?
I see just a couple of questions in the chat box, probably directed towards mine. Just maybe to answer to Kathy, I was starting to type, but it might be quicker if I just speak a little bit. Her question was, how is his treatment for this length of time covered by insurance? So actually a big part of this was he was being treated during COVID. And so there were definitely lapses of periods of time where he wasn't coming into clinic. And so part of that length of time was taking a break between that. And so that might be a good answer for your question. And so it was doing a reevaluation and getting him back into clinic after some follow-ups. And then it looks like Anne, what does plastic space for their protocol upon? What are some considerations and precautions for each patient? Is that directed towards all of the surgeries? Head and neck?
Basically, yes. I mean, you mentioned that it depended, and of course I realize that it depends, but is there anything specific that they're concerned about?
I think that the main consideration is failure of the flap. So when they put the flap in the head and neck region, they just, when a flap fails, it's a whole ordeal and they have to go back into surgery and all of that. In terms of the donor sites, it's just to let everything heal. So the cam boot to restrict any ankle range of motion. And then also there would be usually weight bearing precautions, and the same thing with the radial forearm flap sites, just to ensure that that heals, because they are taking bone and vasculature and they just want to immobilize for a period of time for that area to heal. And then Jen, do you have Therabite, Orabite, any input?
Yeah, I might, maybe I can get back to you on specific indications for that. I'll leave you guys my email as well in case there are some specific questions about like the facial reanimation and like our outpatient side of things. So I'm gonna send that in the chat right now.
So Jen specifically does outpatient pediatrics, and I don't think you see too much trismus there, right?
Yeah, it's usually, it would be typically after some of the head and neck cancers from radiation to fibrosis. We've used like tools just to measure mouth opening, mouth excursion. But a lot of times we're working with post-radiation and doing scar mobilization around this area to kind of open up like anything in the SCM area or anything by the masseter, and sometimes some internal myofascial release, like getting up into this area here in the turquoids.
I think we have a question or comment too about that. Do you want to go ahead, Yarstar? Go ahead, sir. Okay. Do you have a question, sir?
Yeah, I do have a question actually.
Please go ahead.
Thanks Jen for this wonderful presentation first, and thanks to Jenny also. And my question is to Jen, when the patient is coming as an outpatient, post-surgery of 6 months or 7 months, when the patient is having severe trismus or lockjaw. So how can we use some physical agents to mobilize it? So rather than using this traditional Orabite, Therabite, or some sticks to put in and just open it, do you have some, do you have some any other modalities that we can use? Like what we do in India is we used to give some deep oscillating techniques, deep oscillating devices we used to use, and to just loosen up the joint and to open it. And we used to give some extracorporeal shock wave therapy also. According to the patient's need, we used to adjust the frequency of it. Rather than we are going to directly for like 12 megahertz or 24 megahertz, we will just cut down into 1 megahertz or 2 megahertz, and slowly we used to mobilize it. So do you have any kind of thing that you have been using there to easily open the joint? Because the pain the patient will feel while opening the jaw, right? Excruciating.
That's very interesting.
While we are trying to open it.
Yeah,
so
that's
do you
very
have
interesting.
any kind of techniques that you are using to open the jaws easily?
So because I am in mostly the pediatrics section, we don't use as much of those things, but we do a lot of the manual therapy. So most of our, interventions will be mostly gentle massage, or we'll do cross hand techniques to release myofascial, do a myofascial release on that area. And then we'll do a lot of exercises and like prolonged stretches, especially in the neck area, pending each patient, obviously, because it depends on where the radiation was placed or what type of surgery that they have. But no physical agent at this time. I mean, we've used a couple of times the Therabite, but nothing to what you're speaking of.
And I do think so. Lizzie is messaging me about she uses a laser to deal with some radiation issues. Lizzie, do you have anything? Do you use this for trismus or for any jaw range of motion issues? I don't know, she's mostly on the chat. Okay. But maybe laser is an option. We haven't used that personally, but I mean, what we do know about trismus is it's so hard to treat, right? To actually get results for mouth opening that I think there's just so much research on what doesn't work for statistically significant changes in trismus.
So like in patients who are undergoing it, like oral palate reconstructive surgeries, right? When they are placing metal pallets inside their soft pallets and hard pallets, those kind of stuff, right? Even it will be very difficult for us to handle the even terabyte also. So what we do is we used to take these ice cream sticks, right? We used to have the small ice cream sticks. We used to stuck it inside. So because the patients is not getting adequate nutrition, so they are getting into more and more of cancer-related fatigue. So like compromising those kind of stuffs and making patients go easy, we are finding it difficult here. So that's why I'm asking. So is there any steps that you are using? So
Actually, that is
easily helpful for.
yeah, we actually do use ice cream sticks too, or we have like the tongue depressor sticks, and so we'll objectively measure how many sticks they can put in their side of their mouth, and that is something that's easy for someone to get from home or someone to just like get from the hospital that you don't have to purchase.
And we also have this issue with the ice cream sticks, right? The patient used to poke inside. So we have to be careful on that also.
Yeah,
they are
of
poking
course.
inside and they are damaging their inner palate. So it's quite like difficult for us to handle this, mainly for head and neck cancer patients. And how do you use this bandaging techniques for this? So while you are bandaging like this, right? So you are going to just close the jaw. Then how they can able to eat? How we are going to nutrate the patients? I believe Janelle.
Yeah, so you're not applying so much pressure that they're not able to open and close their jaw, right? We still want them to be able to function with this bandaging. It's just we're applying enough pressure to the actual skin and where the increased fluid is to kind of help move that fluid up and out. Again, versus we don't want to limit them so much that they're not able to go about their daily routine because they're wearing these bandages for an extended period of time. You know, you're not just doing it for an hour and then taking it off. So we don't want to make sure that they can comply with the bandaging treatment. So that way, you know, they can go about their daily routine. They can eat, they can talk normally. Yeah, so it's not going to be actually locking their jaw in place.
And I think generally,
do you use any like a face mask or anything?
Yeah, so generally when the patient is doing the overhead bandaging, we're using some sort of foam to provide extra pressure to the area that we're going for, and patient is still able to open their mouth. But yeah, you're right. Any sort of facial compression garment would do something similar and perhaps allow more jaw movement. We actually, in the presentation we had at CSM, we had a video of a patient performing this compression wrapping. We didn't have her permission to use it for this presentation, but yeah, it's not so tight, and the patient is very able to take it on and off, and which is what this particular patient did during the day.
I think it also provides them just with comfort. It helps just kind of make the area feel more contained. So it helps, to comfort them more so than to like immobilize them, I should be saying, yeah.
I wanted to make
for that. Okay,
Yeah,
go ahead, Jackie.
Thanks. I wanted to make a comment, and it's really from Helena Silman Cohen from Israel, one of our colleagues. What her question is about prehab or seeing patients before the surgeries. Could you presenters comment on that? What you think about incorporating that? How easily that would be to incorporate it?
So I think it would be amazing to do prehab, especially for these patients. Our institution doesn't currently have that pathway. We're experimenting with some prehab things for preoperative patients, but I think it would be a great tool to use for this population.
Yeah, Helena's here. Maybe you could, are you using prehab, Helena, in your work?
I think Amit, my colleague, she actually
Oh.
asked the question, but I can definitely answer. I mean, I'm communicating with her. She's a dear friend and colleague. I mean, I used to work at Memorial Sloan Kettering a few years ago. I worked at the breast center. So hi, everybody. Send my regards to Ting Ting. Sure she remembers me. So anyways, I mean, if I'm comparing Israel, which is a relatively very small country, compared to the US, and definitely at Memorial Sloan Kettering, which is a huge, great institution where they have so many resources. We are a small country, and I think only now oncology physical therapy is kind of growing. And we just recently joined the IPT-HOPE, so I'm very excited about that. Yeah, thank you. So, there are definitely remarkable steps, but like I can say I work in a hospital, in Rambam Hospital, which is the biggest hospital in the northern part of Israel. I work at outpatient setting, and I see head and neck patients, but I see them after for outpatient services. And I'm not sure exactly what kind of procedures are done at the inpatient setting. I know they do respiratory treatment, but nobody's lymphedema certified in the inpatient, and I'm not sure they are very familiar with all the side effects from head and neck cancers. But I definitely, as a therapist, lymphedema therapist, and I took some advanced courses about head and neck cancers, so it's different. So I think that we don't have those resources, but I think it's great, and I many times go to the MSKCC website because all of the great resources they have online. And I think that is the future, because I think that people are looking for more information, patients are looking for more information, and it also helps therapists as well.
Yeah, thank you for sharing that. I think, so the research article that I had spoken about, the psychological effects of head and neck cancer, a point in the article was that so much attention is paid to treating the cancer without much attention paid to the after effects. And that's what we're dealing with in physical therapy, right? Their range of motion, their trismus, their lymphedema. But a lot of that gets bypassed in the preoperative and post-surgical stage, because it's just about, okay, we're treating your cancer so you're not dying, but what about all these things after? So I think that's a really good point, is that we need these resources for this patient. They need to be aware of all of this preoperatively. I think that's a good point.
We have forgot the topic like swallowing therapy. Here in India also, right? We do some swallowing therapy, because after if you take some F&D or an R&D, the dissection sites will be very much extensive, and to just help them to feed also, it is like it's a difficult job. We have to train them to feed also, so we have to train. Head and neck cancer rehabilitation is very much bigger part to just go on, because taking on swallowing alone, we can talk around like 2 hours extensively. So those kind of steps are there. And still we are in the learning process. Sure, we will get some new ideas at a later stages also.
Okay, are there any further comments or questions? If you think of something later, you have emails to myself and Ann, but as well as all our speakers, and they can get back to you. And this was a great session. This, it was comprehensive. It covered so many areas, and I particularly liked how you staged things and you went through the progression of the patient so we could see some of the functional outcomes. Representing IPT-HOPE, we will be sending our 4 speakers an International Scholar Award in appreciation for the work that they're doing for us, and helping to advance care globally. And are there any final comments before we sign off here? Okay, so without further ado, have a great day and be in touch. We learn from each other